Okay, let's be real. Diving into sensory systems for the ATI and NCLEX exams, it can feel completely overwhelming. But don't worry, I've got you covered. In this explainer, we're going to unpack the textbook chapters on vision and hearing together, and we are pulling out exactly 20 hallmark, highly tested points. These are the absolute crucial concepts you need to know, distilled down into a comprehensive explanation that's going to save you literally hours of reading. So, let's get into it.
Here is the high-yield blueprint we'll follow to capture all 20 of those points. We're looking at vision, anatomy and assessment, eye medications and procedures, hearing, anatomy and tests, ear treatments and devices, and finally, nursing care for sensory impairment.
Just keep the number 20 in the back of your mind as we go. Getting a firm grip on these specific 20 concepts, that's going to guarantee you a rock-solid foundation for any sensory system question that gets thrown your way on the boards.
All right, kicking things off with Section 1, Vision, Anatomy, and Assessment.
So for point number 1, I want you to think of the eye like a tiny plumbing system. Notice the flow of aqueous humor. That's a fluid produced by the ciliary body. It flows right through the pupil into the anterior chamber and then drains out. But if that drainage pathway gets blocked, well, the fluid backs up and intraocular pressure skyrockets. It's super important because that exact physiological setup is what causes glaucoma, which is a massively tested disease process on the NCLEX.
Moving to point 2, let's talk visual acuity and the classic Snellen chart. For your exams, you absolutely need to know the strict testing standard here. Your patient has to stand exactly 20 feet away. You also need to know what those fractions actually mean. So say a patient has 20/30 vision. The top number is always 20, that's the distance they are standing from the chart. The bottom number, that's the distance at which a person with perfect normal vision can read that exact same line. Basically, your patient can read at 20 feet what a normal eye can clearly see from 30 feet away.
Point 3 is your bread and butter for charting. It's the gold standard for documenting pupil assessment, PERRLA. That stands for pupils equal, round, reactive to light, and accommodation. Now, accommodation just means having the patient focus on a far-off object, which dilates their pupils, and then suddenly shifting their focus to a near object, like your finger. If everything's working normally, those pupils should immediately constrict, and the eyes should converge. You're going to use this on pretty much every single shift.
Moving right along to Section 2, eye medications and procedures.
For our fourth point, we have to distinguish between two drug classes that students mix up all the time. But honestly, it's pretty easy to remember once you see it. Mydriatics dilate the pupil. Just think of the D in mydriatic for dilate. Miotics, on the other hand, constrict the pupils. Locking those two distinct definitions in your brain is a game changer for eliminating incorrect answer choices on test day.
Point 5 breaks down the strict step-by-step procedure for giving eye drops. First things first, wash your hands and glove them. Have the patient tilt their head back and look up to the ceiling. Then, gently pull down that lower eyelid. Here is the crucial NCLEX takeaway. You must drop the medication into the exposed conjunctival sac. Never drop it directly onto the cornea. It's way too sensitive. Finally, just have them close their eyes gently so the medication spreads out. Which brings us right to point 6, a step that happens immediately after administration: punctal occlusion. After you give that eye drop, you apply gentle pressure to the lacrimal sac right at the inner corner of the eye for about a minute. Why? Because it prevents the medication from draining into the body's systemic circulation. It keeps the drug's effects localized exactly where we need them, in the eye. Points 7 and 8 involve a couple of crucial medication rules. Point 7 is the 5-minute rule. If your patient is prescribed multiple different eye drops, you have to wait at least 5 minutes between giving each one. If you don't, the second drop will literally just wash the first one right out. Point 8 is a highly testable, honestly kind of wild side effect. If your patient is having a fluorescein angiography, where they inject dye to photograph the eye's blood vessels, you must warn them that their skin might look a little yellow and their urine could turn green for a few days. If we don't give them a heads up, they are going to panic, making this a top priority nursing intervention. Let's pause for a quick safety check. Think about it. If your patient has a severe visual impairment or is legally blind, what is the absolute first thing you have to do when you walk into their room? You have to announce your presence and introduce yourself immediately. You never want to startle them. Safety and clear communication always come first. All right, let's switch gears. Section 3, hearing anatomy and tests.
For point 9, it's really helpful to see how hearing loss is distinctly categorized into two types:
Conductive hearing loss is caused by a literal physical obstruction in the external or middle ear. Think of a massive buildup of earwax or a middle ear infection physically blocking the sound waves. Sensorineural hearing loss, though, means there's actual damage to the inner ear structures or the nerve pathways leading to the brain. This is often the result of prolonged loud noises or ototoxic medications.
For points 10 and 11, grab your otoscope. Point 10 is the physical technique itself. When assessing an adult, you pull the auricle up and back to straighten out the ear canal. If it were a child, you'd pull it down and back. Point 11 is about what you're actually looking for once you're in there. A healthy, completely normal tympanic membrane, the eardrum, should look shiny and pearl gray. If it's red, bulging, or dull, you've got a problem.
Point 12 covers tuning fork tests. The NCLEX loves these, and students constantly mix them up. For the Weber test, you place the vibrating fork right on the midline of the skull. A normal finding is that the patient hears the sound equally in both ears. For the Rinne test, you're comparing bone conduction to air conduction by moving the fork from the mastoid bone behind the ear right up to the ear canal. The normal finding here? Air conduction should be greater than bone conduction, meaning they hear the sound longer through the air.
Almost there. Section 4. Ear treatments and devices.
Okay, rapid fire time for points 13, 14, and 15. Point 13 is maintaining high alertness for ototoxicity. Common drugs like aspirin and aminoglycoside antibiotics can actually damage the auditory nerve. The classic red flag symptom you're watching for? Tinnitus, or ringing in the ears. Point 14 is all about patient comfort. Always, always warm eardrops to body temperature before you use them. Cold drops will cause severe dizziness. And point 15, if you're irrigating an ear to clear out impacted wax, warm your fluid to 95 degrees Fahrenheit and make sure you direct the steady stream toward the top of the ear canal, above the wax. You want the water to flow behind the wax to push it out. If you blast it straight on, you just push it deeper, or worse, rupture the eardrum.
Point 16 brings us to hearing aids, which is a classic, everyday nursing care topic. When your patient takes their hearing aid out, it's absolutely crucial to teach them to open the battery compartment door. It's a simple little action, but it turns the device off and saves the battery life. Also, pro tip, keep them in a bright, labeled container. These things cost thousands of dollars, and they get lost in hospital bed sheets way too easily.
Last section, Section 5, Nursing Care for Sensory Impairment.
Point 17 highlights a very specific ambulation method called the sighted guide technique. If you're escorting a visually impaired patient, you do not grab them. Instead, you allow the patient to lightly grasp your upper arm right above the elbow. You just walk slightly ahead of them, and they'll naturally follow your body movements. It's a great way to promote both safety and independence.
Let's bring it all home with our final 3 points regarding daily care. Point 18 is about mealtime. Foster independence for visually impaired patients by describing where their food is using a clock face. Tell them, hey, your meat is at 3 o'clock and your vegetables are at 9 o'clock. Point 19, when you're talking to a hearing impaired patient, ensure the room is well lit and face them directly so they can read your lips if they need to. Speak in a normal, clear tone. Do not shout. Shouting just distorts the sound frequencies. And finally, point 20. Any patient experiencing dizziness or vertigo, especially after things like caloric testing where we irrigate the ear to check vestibular function, must be immediately placed on strict fall precautions. No exceptions.
Boom, there we have it, all 20 hallmark points. We've just built a comprehensive test-ready foundation for the sensory systems. But I want to leave you with a final thought today. Acing these questions on the NCLEX is great, it really is, but it's just the beginning. How are you going to take these clinical facts and adapt your actual daily nursing routine to ensure that your patients with sensory impairments never feel isolated, scared, or misunderstood while they're in your care? Keep that in the back of your mind as you continue studying. Thanks so much for joining me on this explainer, and I'll see you next time.